So it's been said that nobody dies from myocardial infarction, but rather that they die from the complications of myocardial infarction. So I thought it would be important to review some of the imaging manifestations of these complications. Complications of myocardial infarction can include both acute and chronic entities. Some of these don't have imaging correlates, such as tachy and bradyarrhythmias and conduction abnormalities. Early pericarditis, for example, is usually evaluated by ECG changes and a fusion on echocardiogram. Likewise, for more chronic entities that may or may not be fatal, not all of these will have imaging correlates that we need to review today. So I'm going to focus in on looking at cardiogenic shock, myocardial rupture, and chronically aneurysm formation with mural thrombus as well. I am going to touch, however, a tiny bit on remodeling. So my objectives for this talk are to recognize the radiographic appearance of circulatory support equipment in cardiogenic shock, and number two, to discuss the similarities and differences between true and false ventricular aneurysms on MR and CT. Cardiogenic shock is defined cardiac dysfunction such that there's inadequate compensation, resulting in insufficient cardiac output to perfuse your peripheral organs, and this usually is in the setting of a stroke volume of less than 35 ml. It occurs in about 7 to 10% of patients in acute MI, especially patients with ST elevation myocardial infarctions. It is a principal cause of in-hospital death from acute MI. Mortality has been reported as higher than 80%. So on a chest radiograph, what will we see? Well, we may see pulmonary edema, but we may not. If it's present, it may be symmetric or asymmetric. The cardiac silhouette is often normal, but it could be enlarged if someone has a pericardial effusion or has had cardiac rupture with hemopericardium. But I think the most important function when we're looking at chest radiographs and cardiogenic shock is to check for support equipment. So I'm going to review some of those. So counterpulsation and ventricular assist devices are the types of equipment we'll see in cardiogenic shock. So I'm going to look at intra-aortic balloon pumps and review both percutaneous and surgically implanted assist devices. Okay, how does an intra-aortic balloon pump work? This is an example here of what kind of a normal systole and diastolic curve look like without the presence of an intra-aortic balloon pump. But here is an example using an intra-aortic balloon pump. So here's a systole, and as we come down into diastole, the balloon automatically inflates. This increases afterload. Then you have a nice pressure gradient within the aorta that allows the coronaries to fill with blood and perfuse the myocardium in diastole. It then deflates before systole occurs again. And this decrease in afterload that occurs actually provides a modest increase in your cardiac output, but it's not very meaningful. Intra-aortic balloon pumps are typically 22, about 27 centimeters in length, and you can see one inside the aorta, what the length of that balloon would look like. So the optimal placement for this intra-aortic balloon pump is to see that radiodense tip in the proximal descending thoracic aorta, distal to the left subclavian artery origin. If you place it too high, you run the risk of the balloon causing cerebral branch vessel ostial occlusion, and if you place it too low, you can run the risk of occluding the renal and mesenteric artery ostia. The other effect of placing the balloon too low is that you'll have ineffective counterpulsation and that you won't get that good coronary blood flow and myocardial perfusion that you're looking for. So there are a few percutaneous left ventricular assist devices that I'll go through with you. Their purpose is to augment cardiac output for peripheral organ perfusion, and how much they can increase that is variable, up to 8 liters per minute. The indications, obviously, for cardiogenic shock, especially when the intra-aortic balloon pump is inadequate, it doesn't provide much help with cardiac output. Its real function is to perfuse the myocardium so that hopefully you can recover some of your contractility you lost. But it can also be used in areas of without cardiogenic shock, such as a complex percutaneous coronary intervention, where you may run into problems with coronary perfusion, and also in post-CABG patients. So what does this look like on a chest x-ray, one of these devices? So here is a chest radiograph showing someone obviously in pulmonary edema, has a defibrillator pad, obviously projecting over our area of interest. And if we kind of change the windowing and leveling, we kind of see a device, it looks radiodense right here, and you follow it along, and it's like, wow, is this an intra-aortic balloon pump that's been placed way out here into the ascending aorta? Well, no, actually, if you keep following down to the left ventricle, you faintly see this little curved cannula. And if you take that and zoom in on it, now you can see it better. And this is what it looks like ex vivo. So what this device does is it actually draws blood into itself in this portion within the left ventricle and above the level of the aortic valve. And so occasionally I'll see this in for more than a day or two, but usually it's incorporated in line with the catheter, and it actively pumps blood out antegrade into your aorta. Typically the duration is hours. Occasionally I'll see this in for more than a day or two, but usually it's truly temporary, meant to be used only for hours. Initially these came out with about 2.5 liters per minute, but now 5 liters per minute can be accommodated by this equipment. Here's another type of percutaneous VAD cannula. Again, here we have a chest x-ray, we have pulmonary edema, and we don't see too much. I mean, you see a Swan-Ganz catheter and some other things here, but if you, again, window and level, you see something faint and tubular right here. We're going to zoom in on it, and again, you see this kind of tubular structure, but it doesn't seem to correspond to the aorta, similar to our other percutaneous VAD catheter. So what is this? Okay, so basically, if you look at it, if you get a picture of the chest, that's all you'll see is this piece of cannula here. But if you come down, it goes way down into the abdomen, and then there's a second shorter cannula next to it. So what happens is people place these cannulas for inflow and outflow, and one is arterial within the femoral artery, the other is in the femoral vein. It's venous. I put this in quotes because it doesn't end up in the vein. What ends up happening is that the cannula is placed through the interatrial septum, either by a PFO or a catheter septostomy, and placed into the left atrium. And then in effect, blood will flow down and out into a pump that is actually external to the patient, and then flow back in to the femoral artery, and the aorta will actually be filled retrograde via this device. So this actually is a little bit more durable than the device I just showed you before, and so you can leave this device in for days, and I've seen it leave up to at most a few weeks. But again, it's a temporary device, and its purpose is a bridge to recovery if you're recovering from your cardiogenic shock more slowly, or what's called a bridge to decision, when you come to a decision to implant a permanent device. So the surgically implantable devices are considered more permanent because they can last in duration for weeks to months or years. And the purpose for them is to either get you far along enough until you can get a transplant if you're eligible, and that can be in patients who are not doing well after their cardiogenic shock, but patients also who deteriorate slowly over time with heart failure. It can be destination therapy for patients who are transplant ineligible. In a few cases, they will actually implant these devices surgically earlier on in cardiogenic shock or in highly selected non-ischemic cardiomyopathy, such as severe viral myocarditis or postpartum cardiomyopathy. So this is an example of a few of these implanted VADs. So there are some components that we can see that are variably visible. I'll show you in both of these devices. Sometimes it's hard to see the inflow cannula, a little piece of it that's sitting within the left ventricle, so it's surgically implanted into the left ventricle. Then you have a valved conduit, a pump. This one happens to be pulsatile. This conduit comes back out, and then it's harder to see this portion of the conduit that's coming up and into the ascending aorta. So it's completely bypassing the left ventricular outflow tract. The wire that you see here goes outside, external to the patient, to a battery pack. The other device is similar, left ventricle, valve conduit. This is continuous rather than, so it's a non-pulsatile motor going to another conduit. And then you don't see this piece very well, this cannula that's extending up into the ascending aorta. So I've showed you these pieces of equipment in cardiogenic shock, and in most of those cases, the reason they're getting them is because of left ventricular pump failure. But there are other causes of cardiogenic shock and mortality that are far less frequent, but also have a very high mortality. And so I'd like to go over a few of these entities with you. A myocardial rupture can occur with either the free wall, anterior, inferior, lateral, but also parts of the myocardium that are not free, that is the septum or within the left ventricle, one of the papillary muscles. So I'm going to just show you a little bit about papillary muscle rupture. The septal ruptures usually result in basically an acute VSD with left to right shunting. These patients will usually be assessed with echocardiography. It may be possible that papillary muscle ruptures too are more commonly evaluated in the acute setting with echocardiography, but there's some important findings I'd like to kind of review with you. So papillary muscle rupture or chordae tendon rupture can result in a phleum mitral valve leaflet, and this results in acute post-infarction mitral insufficiency. And like with other cases of cardiogenic shock, the cardiac silhouette may not be enlarged, but there may be pulmonary edema. And with papillary muscle rupture, there's a specific pattern that we can see in the right upper lobe. So now how does this happen? Well, you can imagine that with chronic mitral regurgitation, the left ventricle has time to accommodate that volume and dilate and stretch. But in the setting of an acute MR with papillary muscle rupture, the left ventricle is not ready to accommodate that. So the physiology becomes almost more of one of an acute mitral stenosis, if we will, of increased pressure, of obstruction. And so this kind of acute pulmonary venous hypertension occurs and is directed selectively toward the right upper lobe pulmonary vein. As you can see here, here's the mitral valve plane, the left ventricle myocardium, and the right superior pulmonary vein, resulting in this picture. So somebody comes into you with an ST elevation myocardial infarction or is in cardiogenic shock, and you see this. If they don't already know about it, you can suggest papillary muscle rupture. Free wall can also rupture. I've never personally come across in my imaging incomplete free wall rupture, but I did include some pictures from the literature here, and that could be intramyocardial or if there's only a tiny piece of a layer of myocardium remaining, subepicardial hematoma. And this is just showing you a nice example of that. These are 4-chamber, 2-chamber, and short axis views from steady state fast precession cardiac MR and delayed enhancement. The white areas on the steady state fast precession extending into the wall correspond to the area of intramyocardial hematoma. And on the delayed enhancement, what you can actually see is this is the same area of the intramyocardial rupture, and the delayed enhancement here is actually some infarct. The area that is dark here is an area of microvascular obstruction, otherwise known as no flow, no reflow. And this does not get any delayed enhancement in it because contrast never leaked out into the myocardium in the first place. Let's look a little bit at complete free wall rupture. Now, when you see hemopericardium, if it happens acutely, obviously you may end up with tamponade physiology. Most likely, these patients are going to be assessed with echocardiography at the bedside, but you may end up getting a chest X-ray and seeing an enlarged cardiac silhouette. But I wanted to talk about something that is actually more of a chronic consequence, which is pseudoaneurysm formation. So a rupture of the left ventricular free wall is usually catastrophic and occurs about 4% of patients after MI. But in patients who don't die of the rupture, a pseudoaneurysm can form where it's contained by pericardium. And unfortunately, it is risk of further expansion and rupture. And so when you see these, they will go to aneurysectomy. Common location that we see them is posterolateral LV wall, but they can occur anywhere, including in the anterior wall. The pericardium surrounding this area can have delayed enhancement. And if it does that, it would definitely mimic a myocardial infarction with delayed enhancement. There may or may not be a luminal thrombus within the pseudoaneurysm. And I just want to compare and contrast that with a true aneurysm. So in a true aneurysm, there's myocardium with 3 intact layers, but it's extremely thin, and it will show delayed enhancement. It will have abnormal motion, be akinetic, or possibly paradoxically bulged during systole. And very commonly, these are in the apex or apico-anterior posterior wall, uncommon. They may or may not have neural calcification in the area of the infarcted myocardium, and there may or may not be luminal thrombus. But unlike pseudoaneurysm, these rarely rupture. However, some of them do end up needing to go to surgery sheerly because of their size. So a true versus false aneurysm. This study came out which did a nice job really showing how to differentiate between true and false aneurysms and what pitfalls there are in evaluating them. So for example, we'll look at this image here. This is a vertical long axis view from delayed enhancement cardiac MR. This shows a very thin anterior wall extending to the apex with delayed enhancement. There's no mural thrombus in this case, but you'll notice the dimension of the orifice internal diameter to a parallel diameter. That's the maximum within the chain, this part of the aneurysm itself. And it's basically a 1-to-1 ratio here between these two. And that's what was found, that in true aneurysms, this ratio should be 1-to-1. Look at this case. It looks basically very similar to the other one. Oh, that looks like a very large anterior wall MI. Got some mural thrombus here, delayed enhancement of the myocardium, but in fact it's not. This is actually a pericardium around a pseudoaneurysm that's enhancing. And in this case, if you notice the orifice, internal diameter 6.5 compared to 8.5. And so there's a very big difference in true versus false aneurysms. These are just samples of cardiac CT pseudoaneurysms, but you could see that same relationship. These are examples of true apical infarcts, true aneurysms. These, they're a dime a dozen. You see this on all kinds of imaging, whether it's abdominal CT or chest CT with myocardial thinning, laminar or bulky thrombus, calcifications. So we see these very, very frequently. And many of these patients, this is a completely incidental finding. You don't necessarily need to do anything about resecting any of these. They're asymptomatic. They have normal ejection fractions. However, there's one case I do want to mention, which is these very large anterior wall MIs that sometimes do involve the apex. And because of their geometry, wall stresses can promote infarct expansion, thus resulting in dilatation and remodeling. This is inversely related to survival and event-free survival, and it could begin immediately after the MI and evolve over days to weeks. Sometimes that happens more rapidly, early, late, or is continuous and progressive, but it doesn't matter which way it happens, you have problems with survival in all these patients. This is not only prognostically important to look at the ejection fraction, but also the end systolic volume, and this end systolic volume increases have been associated with significant increases in relative risk of not surviving. But one thing I wanted to point out very importantly for these cases is, unlike those little tiny apical aneurysms, which are seen all the time, asymptomatic, dime a dozen, you actually don't see mural thrombus that often with the anterior MIs. And why is that? Because actually the incidence of mural thrombus formation is very common in these, especially in the first 2 weeks. But these patients, because they're very sick, they're chronically sick, they are symptomatic, these anterior wall MIs are going to be followed often with serial imaging to look for that progressive dilatation. So these patients will be followed, they're going to be evaluated for thrombus, and they're going to be anticoagulated based on American Heart Association guidelines. So just summing up, I have 2 real quick cases to show you at the end. Is there abnormality in either view of this chest x-ray? Yes, there's one on the back right here. This is a posterobasal LV aneurysm. Is it true or false? If you look at this part here where this little piece of papillary muscle comes up, you'd be falsely thinking that this is the orifice. But if you cut in a little further toward the septum, you'll notice that this is actually a true aneurysm. And then this ratio of orifice to internal diameter is 1:1. There's also a little bit of mitral regurgitation in this patient. Basically, if you go into other planes, you can see this much better, seeing that big aneurysm here with a very wide orifice. If you look at this patient happened to have an abdominal CT, kind of same thing, you might get faked out by muscle coming up here in this kind of more sagittal plane, but looking at it another way, big wide open orifice. Same kind of thing, just going from cranial to caudal, coming down on this, very big wide orifice. There's no little neck on this. And here in this case, you barely saw any delayed enhancement. Actually, had to change parameters to see any of this through the aneurysm wall. So there's one where it was almost a false negative to see the infarct itself. More toward the apex, it was a little subendocardial infarct too. And then this patient is having an LV aneurysm and a mitral valve repair and did just fine. But this patient, I'll just show you super quick, was admitted for ST elevation myocardial infarction, had SPECT imaging, had a big anterior wall MI. Nobody noticed this big bulge. On the attenuation correction CT, patient presented sometime later. This was called an aneurysm, but nobody made a phone call to say, hey, well, this could be a pseudoaneurysm. So not much was done with this patient. It was kind of lost to follow-up, and the patient was readmitted, and this patient actually did have a pseudoaneurysm and passed away a few hours later. So a real missed opportunity here, both on the SPECT and a chest X-ray. So I'm just bringing this here to your attention because we really have to be very vigilant about these findings, and if there's any concern for a pseudoaneurysm or enlarging aneurysm, make the phone call, get the imaging. This person never got a chance to go to that imaging. So these are the things I went through a little bit with you. Cardiogenic shock. Edema may be present or absent selectively in the right upper lobe with acute MR, and you should anticipate and recognize the support equipment. And you should be able to closely scrutinize post-MI images to be concerned for an aneurysm or pseudoaneurysm, and then use cross-sectional imaging to discriminate between the two, especially using that ratio of the neck to body luminal dimension.